So I'm Dr. Thomas Meek. I work here at the primary care clinic that we have. It's a residency-directed clinic. So we're involved in graduate medical education, which for those who don't know, teaching young doctors, they are doctors, they've graduated from medical school, but just sort of polishing them off, getting them to be to where they are with confidence and some degree of experience and up and running. That's what we do here. So part of that in running a residency clinic is to try to get them research experience. That's sort of what we're talking about today. Is we had an opportunity to become involved with the National Research Network, which is affiliated through the American Academy of Family Physicians. So sort of a big outfit. And they have an ongoing study that we were selected to be a part of, one of 44 sites, and that is to be involved in placing a clinical pharmacist to study how that can help improve patient outcomes. The overview of the study is really broad. It's broad strokes because not a lot of primary care practices have a pharmacist right there in the practice. So that's the whole idea, is to see if putting a pharmacist in the clinic can help and how to do it. So there's 5 big outlines that the study's trying to address. And so number 1 is to establish the baseline. What are the needs of each individual clinic? So for us, identifying that is pretty much diabetes, poorly controlled diabetes, and then what we can do to improve that. Establish what the best practices are. So, determine from our clinical experience what are the best things to achieve the best outcomes and how to use a pharmacist to do that. Try to define what are the systemic requirements that are needed in the system to get the job done. And then using key metrics to measure that. And then once it's all said and done, to collaborate with these other 44 sites, sort of network, interact, and share what's working, what's not, and replicate what's working to make outcomes bigger on a kind of a national basis. The study itself is through University of North Carolina, through their School of Pharmacy, and then also through the University of Minnesota. And so there is some funding for that. They give us some funding to help promote what we're doing and maybe get some of the things that we need. So some things that have come out of that is getting our own A1c machine, which is just the ability to measure an average blood sugar over about 3 months. And that gives you a better over idea of what someone's control is versus just what their fingerstick blood sugars were at home. And so that's one thing that we're doing. Also, some of the funding has helped us get in a line with samples that are available through a number of the different pharmaceutical companies. So a lot of diabetes medications are really expensive, especially the new ones. So having access to samples for people who can't afford them, that's helpful just to get things started. But even more importantly, just sort of bread and butter of diabetes monitoring is finger stick lancets, test strips, glucometers. So we have some availability to access to those to be able to give to patients or share with them when they're here in the clinic. Christy, our pharmacist, can speak more to this specifically, but she has the ability to spend an hour with each patient. So as busy physicians covering a number of different things, blood pressure, cholesterol, the diabetes, back pain, those are a lot of things that would happen in a typical clinical visit, is that we can identify the need that, hey, this diabetes is not well controlled. Let's get you plugged in with our pharmacist. She's a doctor of pharmacy, clinical pharmacy, and she's also a certified diabetes educator. So she can really focus in and focus on education, determine what their needs are, meet them in the middle, kind of get an understanding of what their understanding themselves is of the disease process, and go from there. Thus far, it's been the early broad strokes of the study, just to identify what our baseline is, what we want to focus on, what we're doing right and what we're doing wrong. A big issue is transportation and money. Ability to pay for meds, ability to get here on time. So one of the hopes is, instead of referring a patient somewhere else, we don't have endocrinologists here in Burke County, but to say, hey, we've got a clinical pharmacist, a doctor right here that can help you right here in our clinic. Just come here next week and kind of get the ball rolling. So hopefully it's a matter of convenience. Christy is also, not only is it involved in our clinic, but also at Mountain Valley, so with the internal medicine residents as well. it's maybe one of the best possible alternative. So when we ask patients, hey, you have really badly controlled diabetes, we need to get you to see an endocrinologist. That means driving to Hickory or Asheville or Shelby. They don't want to do that. A good plug for what we're trying to do is say, hey, just come back here to the clinic. And it's not an endocrinologist, but we are physicians. We have a really good understanding of the nuts and bolts of how this disease works and what we can do to help you. And then we can use our pharmacists to navigate that water, to maybe give you some prompting phone calls, reminders to get back here. You have, dedicate an hour to go through the educational process, and then even navigate the waters of maybe getting samples, payment plans, coupons, that sort of thing. In our county, Burke County, it's a mountainous area. The geography, keeps people, there's some transportation issues, and that's a thing. So diabetes control is suboptimal where we live. And so we're really fortunate to be a part of this study in hopes that it can better, improve outcomes, get patients the medication they need, maybe even more importantly, get them the understanding of their disease, and make people better.